Welcome to this series of interviews with the giants of cardiothoracic surgery. My name is Leanne Harling and I'm here at SCTS in Manchester with Professor Mattia Glauber. Professor Glauber, you are currently Professor of Cardiac Surgery and Director of the Unit of Cardiovascular Surgery at the Istituto Clinico Sant'Ambrogio in Milan. Having trained in Germany, you worked across Europe and Switzerland and France before settling back in Bergamo in Italy in 1989. You later moved to adult cardiac surgery in Massa, where you managed to combine your hectic clinical schedule with a highly successful research programme at the Institute for Clinical Physiology. After 4 years, you became Chief of Cardiac Surgery at Massa, creating a unit that under your leadership became a centre of excellence in adult cardiothoracic surgery with a prestigious international reputation. After 20 years in Massa, you moved back to Milan, where you became Director of Cardiac and Vascular Surgery. In addition to performing over 10,000 cardiac surgical procedures, you also have a very keen interest in surgical research and have published over 200 peer-reviewed articles. Your dedication to establishing and promoting innovation in cardiac surgery is not only demonstrated clinically by more than 3,000 minimally invasive procedures, but also through your highly active research programme, development of your own innovative device, the CardioVision Glauber aortic clamp, and your avid commitment to training the future generation of surgeons. It really is an honour to talk to you and someone with such vast experience and knowledge, particularly in pioneering the adoption of minimally invasive valvular surgery. I thought perhaps we could begin by discussing the adoption of minimally invasive surgery over the past decade and how this has differed internationally, both within Europe and further afield. Professor Glauber, welcome.
Thank you.
So I thought perhaps we could start by discussing the barriers to adoption for aortic valve replacement and mitral valve replacement.
So thank you for being here. Thank you for this kind invitation and for the opportunity to give my impression. Coming to this first question, I would say that there are mainly 3 barriers. One is surely the lack of a real clinical evidence of superiority of minimally invasive surgery. There are many publications reporting the advantages of minimally invasive, evaluated by propensity score studies, evaluated by multi-center experience and meta-analysis, but a real randomized study was not actually performed. So we have this lack of information and we need surely to find all the benefits from other type of studies. A second point is surely the complexity of a new type of surgery. Even if it's not so new, but minimally invasive was introduced at least 15 years ago, but the adoption rate is still very low. For mitral valve repair is increasing, it's around 50%. For aortic valve is still under 20%. Adoption rate depends, like for each innovation or innovative device or innovative technology, from the complexity to use, the complexity to adopt, even related to the skill of the surgeon who has to use this technique. And the skill is also, and we come to the third point, effect that is influenced by the learning curve. The learning curve is mandatory, needs something that is not only related for the surgeon, but for all the staff who is working with the surgeon, Obviously, the surgeon plays a very important role, and his learning curve needs time, needs a proctor, needs a program, and needs also a certain number of procedures, which can be calculated for a mitral valve program if the surgeon is formed for mitral surgery, about 40 to 50 procedure, and the same for aortic valve surgery. He needs a little bit less. And for aortic valve surgery, we are now facilitated by the introduction of sutureless technology. That's an important new facilitating device.
Excellent. And you mentioned a lot about learning curve. How do you find training future trainees? You talk about individual surgeon learning curve. Do you think that over the next forthcoming years we will train our juniors in the procedure from the beginning to try and remove some of that element of learning curve or facilitate that learning curve? Do you think that would make it any easier?
That's sure. We have always to make the difference between learning the minimal invasive surgery or learning the mitral repair or replacement surgeries. There are two independent learning curves that can obviously overlap, but it's faster to learn or to teach a surgeon who has experience with mitral repair and replacement. The case volume will reduce if someone has in his background experience in mitral surgery repair, that's sure.
And focusing a bit on mitral repair first of all, and then we'll move on a little bit to aortic if hopefully we have time. What are your criteria for selection for minimally invasive mitral repair?
There are very few contraindications to a minimal invasive mitral surgery. As much the patient has comorbidities, as higher is the benefit for the patient. And I select very few situations as absolute contraindication. Which are a real previous surgery, complex previous surgery from the right side, or if there is a severe pulmonary emphysema. Another contraindication is a pectus excavatum. But for the rest, we don't have any particularly complex situation.
And things like atrial size, does that impact on your choice of minimally invasive versus open procedures? Large atria is not, in your opinion?
Absolutely not.
And from the surgical approach to minimally invasive mitral, can you describe to me the various alternative surgical approaches to minimally invasive mitral repair, and what's your preference as far as mini stenotomies versus mini thoracotomies versus port access surgery?
For aortic, I prefer mini thoracotomy. More than 90% of the patients are treated by a right thoracotomy, and the decision making is done with imaging. A CT scan, even without contrast, has to be performed before, and now you can really predict the complexity. You can reconstruct the real anatomy of the patient, even in 3D, and you can exactly decide where to go, in which space, which is the distance, which type of valve is more easy to use for that patient. So with some experience, you can really plan in your mind the procedure before. For mitral, I always go in the fourth intercostal space, very lateral, and I even prefer an antegrade flow. So in most of the cases, I cannulate the ascending aorta for giving an anterior flow perfusion to the patient.
So that was going to be my next question. Cannulation strategies. How do you select your? You mentioned antegrade flow. How do you select your cannulation strategy? Or
perfusion strategy is important, and from the perfusion strategy, we even decide the arterial cannulation site. Venous is always percutaneous from the groin. Arterial is, in most of the cases, the aorta, which can be easily cannulated. Also here we need a short learning curve, and we don't need to enlarge the site of the thoracotomy. It's only a matter of skillness and of practice, obviously.
And how about cross-clamping? What's your opinion on aortic cross-clamping via a Chitwood clamp, for example, or using an endoaortic balloon?
External clamping is routine. Second choice is beating heart or ventricular fibrillation in mostly redo cases. In very rare situations, the endoclamp can be an option. My choice is related to the fact of having a mild to moderate aortic incompetence that can impair the visualization during a fibrillating procedure.
Okay. And I think one of the other things that really impacts on early surgical practice in minimally invasive is when to convert. When, particularly in your early experience, what would you recommend to those people, particularly starting out? When should you know when to stop and say, okay, move to an open procedure, or what's your experience in that?
The reason to convert mostly are related to bleeding problems. So if you cannot manage bleeding complication related to some accidental injuries to a cardiac structure, that can be an artery, a vein, the ventricle itself. So the best obviously is to avoid this type of complication, and to do it you need to really standardize step by step each single aspect of your procedure. Before converting, I always suggest to enlarge the thoracotomy, because even with a larger thoracotomy you can manage a lot of problems.
So you mentioned earlier on about comparability of outcomes between minimally invasive and open procedures, and the need to prove ourselves by being better than open procedures to therefore justify minimally invasive surgery. Do you think that that's really necessary? Should we always have to justify being better, or can we be comparable but offer an improved hospital experience for the patient?
The patient are asking now for a minimally invasive procedure. They go on the internet, they see that the mitral repair or aortic procedure can be done in an alternative, less invasive way. So they comes and they ask you for a specific procedure. That's more and more common. I think that in the era of evidence, in which we have to define new guidelines, we need to prove that we are better. My concept of minimal invasive, in which I started 10 years ago, and the first question was how I can prove to be non-inferior or superior, was to try to reproduce a procedure which was as much as possible similar to a conventional full sternotomy procedure. Reason why I decided to cannulate the ascending aorta, to cross-clamp directly the aorta, to give cardioplegia from the aortic root. The only difference was in the venous drainage, which was performed through a percutaneous venous cannulation, and the use of special instrumentation or different devices and so on. But the quality of repair, we know, is as good as in full sternotomy, and the quality of a replacement is as good as, so there is no difference in medium and long-term quality of repair, of recurrency, of regurgitation, and so on. And this concept creates a procedure that is as similar as a full sternotomy. Direct aortic cannulation, antegrade flow, direct cross-clamping, cardioplegia in the ascending aorta. That is a way to prove that minimal invasive can be superior.
Do you think that perhaps we miss some of the benefit by not looking so much at quality of life outcomes and slightly more qualitative outcomes that may actually demonstrate a lot more superiority if you were to look a little bit further down the line? We focus quite heavily on morbidity and mortality outcomes. What's your feeling on that?
We have also in the actual era to look to the social cost of the procedure, which is not only the hospital cost once the patient leaves the hospital, so the pure cost of the procedure, a shorter rehabilitation, a back to work which is much faster, a more acceptable procedure from a psychological point of view is also something that gives an improvement to the procedure. So there are many reasons to do minimal invasive. Think minimal invasive.
Absolutely. And just finally, what do you think is the future of minimally invasive mitral valve repair and replacement?
We are faced with innovative solutions which are proposed by companies that has to be performed by probably not only cardiologists, but by a new figure, professional figure, which is in between the interventional cardiologist and the surgeon. It will take a long time. For mitral, it will be not so fast as for TAVIs. But I think that, and this is fascinating, that technology, research, development will bring us more and more solutions for treating mitral patients. In my opinion, anatomical lesions like a prolapse, like a chordal rupture, should be treated surgically. Functional patient with secondary mitral disease due to cardiomyopathies or any other reason has a good rationale to be treated by other options.
Excellent. Well, thank you so much. It's been fascinating talking to you, and actually could go on for a lot longer. So, but we'll have to stop there. Thank you so much.
Thank you.
It's been an absolute pleasure.